Good morning, everyone. This is Kathy Randall, and this is October's Q&A call. And I'm having a smidge little technical difficulty here, so I'm going to actually just try to share my screen instead of slides for a change. So let's see how this goes. All right, so I hope you're seeing the live Q&A call here, and I'm just going to back out and make sure it's all there for you. There we go. All right, so today is October 26, 2015, and this is the live Q&A call. So one of the most common questions that I get in working with aEEG and working with hospitals really around the world of using aEEG in the NICU is the question of who to monitor. So I thought I would just quickly run through a few of these suggestions. So of course, I think the most obvious baby that we think of to monitor, and many hospitals kind of entry into aEEG monitoring is really the baby who's had an asphyxiating event around the time of birth. So of course we know the definition of these babies who maybe are coming to us with some sort of distress and who have had a difficult time at immediately either during delivery or immediately after. So they may have been hypotonic, they may have required resuscitation, they may have low APGARs or even a low pH. And so basically you're assessing them for their qualifications to cool or not to cool. And one of the kind of really helpful publications that came the utility of aEEG for these hypoxic babies was really this meta-analysis that happened by Ed Spitzmiller from Miami Valley in Ohio. And really what this particular paper really showed, and again, if you haven't reviewed this meta-analysis, it's really great, and I would recommend going back and looking at it, even though it's 8 years old now, I guess. But basically what he said is that amplitude integrated EEG should be used in the initial evaluation of any term baby meeting the criteria for cooling and really the criteria for HIE. And the other thing that he really brought forth to us was that aEEG can be interpreted without extensive formal training. And so although I think that the aEEG course that you've been doing online is quite in depth, it's not really extensive in the sense of it taking you several years to finish or requiring any kind of fellowship. With just kind of the basic knowledge, we all can begin to use aEEG confidently. So we talk a little bit about the obvious, and of course it's that HIE baby. But again, the other babies that we think are pretty obvious to use amplitude integrated EEG are babies who are suspected of having seizures. So these are babies who are having abnormal movements, maybe changes in vital signs. And of course, number one is apnea, especially apnea of the term baby. So when a baby is otherwise well and is having apnea, we are concerned that the baby will be having seizures that we're unaware of. So we want to be sure to have that baby reviewed with aEEG to look for those subclinical seizures and, well, or maybe they're clinical, right? So having apnea, but subclinical non-convulsive seizures. And we want to be looking for those because, of course, we know that that's a sign of potential stroke or other injury in the brain. And let's just, again, review, again, the kind of an old paper here, but this is from Painter in 2006. And this is really just reminding us that clinical seizures may be difficult to diagnose and oftentimes overlooked. And they are really subtle. We all know these signs of our babies who are having seizures. They are oftentimes things like lip smacking or sucking or just rhythmic movements that are just not quite what we would say as a classic seizure, and eye fluttering and things like this, but they're easy to overlook, but they are definitely signs of abnormal neurological activity. In non-paralyzed babies, only about 20% of electrographic seizures are going to provoke clinical signs. So if we do this sentence the other direction, this means that 80% of the time there will be no clinical signs of seizures. So this is really where we have to rely on having other tools to help us. We are just not good enough at being able to pick out these seizures. And it's not because we're not trying, it's because these seizures oftentimes are subclinical. The other times when clinical manifestations are there, there's not the electrographic part. So it's very complicated. But when there is abnormal movement, there is often a seizure. So it's worth going and looking anytime you have a baby who is doing funny abnormal movements. So, all right, so that we've talked about the hypoxic baby, the seizing baby, and then the one that is obvious, but maybe not oftentimes thought of to monitor are the babies who are muscle relaxed. And I know we don't have to paralyze our babies nearly as much as we used to, but there are oftentimes babies who come back from surgery who have had a significant amount of anesthesia, babies who are having procedures that are really sedated. So it may not even be that they're fully muscle relaxed, but that they are just significantly sedated. So these are babies that obviously cannot demonstrate physically that they are having seizures. And so I think they're a group to really consider, that any infant who is ill enough to require that level of sedation could be at risk for having seizures, and worthwhile to maybe get the aEEG on that baby right away. And then the final group is just the babies who are just kind of neurologically impaired or abnormal. So just not doing the things that a baby of their age should do. So this goes back to the term baby having apnea. That is not what a term baby should be doing. So that is neurologically impaired or dysfunctional. Babies who are term babies, especially who don't eat well, who are discoordinate and do not feed well or in a coordinated way. That is a typical skill that a term baby especially should have. So when a baby is having feeding difficulties, maybe that's a sign that something neurologically is going wrong. So let's talk about maybe the not so obvious kids. We talked about the obvious ones, but the not so obvious. So number one on this list is the metabolic disease. So we know that babies who have metabolic disease are oftentimes going to present encephalopathic, potentially with seizures. So although their diagnosis may not be really in our face when they first arrive in the unit, these are babies that we want to consider just for their presentation. Again, going back to the last page, saying they're neurologically impaired or abnormal for what we would expect for age. These are great babies to review, as well as to do long-term monitoring, trending on them, because as their disease is managed, you oftentimes see an improvement in their aEEG background. So they're a really great group to use. And if they're not having obvious seizures, it's just encephalopathy, then it is something that you can use the aEEG for, because maybe it's not that you have your full video EEG on those babies. Meningitis. Again, these are babies who are definitely having irritation of their brains, and so they would be definitely a group that you would want to consider. These babies oftentimes have subclinical seizures, are very ill, and have difficult manifesting clinical seizures. So really for seizures, seizure detection mostly, but also to look at background and to see if that actual infection is having an impact on their actual background pattern. Maybe there's a little bit of discontinuity where there shouldn't be. Again, just looking for those clues that something's going on. Then we have babies who are maybe on methadone or who are experiencing abstinence of some sort. So these are babies who are at risk for at least having seizure-like behavior, as well as a loss of what would be considered kind of their normal continuity. So this is babies who are definitely not our obvious kiddos, but kids that you might want to consider monitoring at least intermittently throughout their stay. Another group of patients is our hyperbilly babies, and not that I'm saying we should monitor every hyperbilly, but certainly it's there's babies who come in with very high billies who have abnormal movements, who maybe are doing some posturing, and I feel like aEEG could be really helpful for these babies, where we could see whether or not the abnormal movement is really from their increased hyperbilly, or if it is in fact that they have some sort of underlying infection that maybe is contributing to their hyperbilly, especially late hyperbilly in older babies. And I don't mean super late. I mean like, day 5 or day 7, where you're thinking, why is this billy still so high? This kid is eating well. He's older. Yeah, I myself have taken care of babies who have come in on that day 5 with apnea, have hyperbilly on top of things. And it's a little bit of a confusing picture. And I've actually monitored these babies, and they've been in status. And so it's interesting that that's a group that I think sometimes are hyperbilly. There may be another underlying infection reason as to why they're having kind of a prolonged recovery from just the natural transition, and a good group to maybe think of, especially if you have a baby who is like extremely lethargic, and again maybe increasing fontanelle or pressure in the fontanelle, so things like that. So just to kind of plug that as an experience that I've had where I found aEEG to be helpful. I've taken care of babies who are doing weird arching, and then their aEEG is normal. So I don't worry so much about seizures in those kids, but certainly they're sometimes have worrisome behavior. The middle one there, I'm going to actually come back to because I actually added some extra slides about that. But that's cardiac babies. So I'm going to come back to that a little bit more. And the other time is just when we're having other medications, and we're going to just want to see the effect of these medications. So maybe it's just to monitor transition or the effect of a medication coming off of phenobarb, maybe giving some sedation. So just thinking about the fact that these medications we oftentimes give can have an effect on our aEEG. And surfactant is an interesting one. I wouldn't put aEEG on just to monitor the baby during administration of surfactant, but certainly there have been many case reports of surfactant administration, the administration process, actually causing a rather flat background pattern just for the 10 to 20 minutes immediately following administration. So if a baby is already at risk and you have aEEG on and you're giving surfactant, I just wanted to kind of draw your attention to the fact that there have been some case reports of some pretty significant suppression of aEEG, again, for 10 to 20 minutes after administration. Not really sure why, but just so that if you were incidentally monitoring and giving it, you might see that. So I talked a little bit about congenital heart disease, and this is just an interesting article from, it's a nice review article actually from 2010, talking about neurological outcomes and congenital heart disease. And I love this quote where it says, well, it's true that the majority of children with congenital heart disease will survive. Up to half of the surviving children will have impaired neurological outcomes. And this is across a wide spectrum of domains and diagnoses. So what do we know about these kids who have congenital heart disease? Well, when we look at them pre-operatively, and I think it's important to know that there's been a lot of research done about these babies pre-op, that at that up to 59%, when we look at their head ultrasounds, can have abnormalities, that up to 53% of their MRIs pre-op show brain abnormalities, and that 20%, almost 20%, can have seizure activity pre-op, and that a third of them have background pattern problems. So just maybe a lack of sleep-wake cycling. I've seen that a fair amount in babies who have rather low cerebral sats. It seems like if they're trending towards that 50% on their cerebral saturations pre-op, we tend to see, if we're monitoring their aEEG, we tend to see that they have a lack of sleep-wake cycling. So I think, again, it may just be that they have a little more discontinuous trace, but certainly I know for myself I've seen just this lack of sleep-wake cycling. And we know that hypoxia can disrupt that. So I think it's interesting, and maybe a group that we haven't yet really looked at fully, and that we should look at more consistently. So when we kind of look at this big, long list, there's really not many babies in the newborn intensive care that we shouldn't be using aEEG for. So I think that it's time that we get that aEEG monitor out. We dust off our policies and our protocols. And we encourage each other to use aEEG more. And I really today only talked about the babies on the left-hand side, the term babies. But there's certainly a lot of evidence on preterm babies as well. And if you're taking the course, you have access to the bonus presentation by Dr. Gabriel Veriani, who talks about the use of aEEG in our preterms. So not to spend too much time on that, since there's such a great overview available to you. So anyway, so term babies, we've talked about many of these today. And then, of course, there is a place for preterms as well. So as we, oops, let's see what happened here. Screen sharing started. Okay, I guess I'm back. So aEEG, one of the limitations and some of the strengths, just wanted to kind of just review these really quickly. So some of the strengths of aEEG. So if we have all of these babies that we want to use it on, what are the strengths? Number one, it's available to the unit all the time, 24/7. The trends are really easy to read over time. So reading them over time is really helpful. It is quick to apply, meaning we don't have to wait for a EEG tech to come. It detects most of the seizures, so around 80%, whereas when we look at for electrographic seizures for our, using our own just clinical skills, it's only about 10% of the time. And the strength is that it just requires some training. So some training is needed for that. Limitations. It does use NICU time for application. So we do need to have staff who are willing to apply this aEEG. It doesn't pick up the nitty-gritty. It doesn't give us a ton of detail. So it's less background activity. And it's not really designed for the beat-to-beat, moment-to-moment information. So it doesn't see the beat-to-beat. It has less background detail. Seizures that are short in duration are difficult to detect. So the seizures that are not more than about a minute in length are hard to see on aEEG. And remember that it takes about 15 seconds to make one line on our aEEG pattern. So in our 3.5 hour pattern that we see, it takes about 15 seconds to make one line. So if your seizure is about 10 seconds, not going to really see any change on your aEEG monitor. But when we start getting into 30 seconds, a minute, and 2 minutes and beyond, the aEEG pattern becomes much more easy to identify. The limitation is that some training is needed. So it's not that you need extensive training, but some training is in fact needed. So again, just reminding you that although there are many, many strengths of aEEG, there are some limitations that we accept. So it's easy to apply, but we don't get as much detail. We have great trends, but we don't see a lot of the nitty-gritty. We can see most seizures, so 80% to me is better than 10%, but short seizures are hard to see. So I think those are just a really quick overview of the strengths and limitations, but hopefully it gives you enough encouragement to keep using it. The screen is stuck. And let me just put this on pause really quick. Well, let's see if we can go back here and hit this button. My apologies. Okay. All right. Sorry about that. So anyways, as we're just wrapping up here, I just wanted to remind you that if you haven't yet pulled the 2011 American Clinical Neurophysiology Society guidelines, so the ACNS guidelines on continuous EEG monitoring in neonates, I would highly recommend this. So the ACNS put out these guidelines. They are fantastic. They talk about the type of monitoring, the type of patients, as well as when babies who are on continuous EEG how frequently their patterns should be reviewed, and what kind of reporting should happen. So it's a really great guideline. It helps really to establish, if you're caring for these kinds of infants, what should you have in your unit. So it's great justification for buying equipment, for getting more training, and so on. So I love these guidelines, and thanks to this group of amazing physicians who put this out for us. So just as a final little wrap up, I'm leaving in 5 days for Africa. I know all of you in my community love babies as much as I do, and I'm actually going to be part of a group called Tiny People Matters, and doing a little medical safari. So I'm going to be teaching the program Helping Babies Breathe to several different places, and in Zambia. So I'm actually going to the Zambia area, and going to be doing some clinics, some mobile clinics and whatnot. So if you would like to subscribe to my photo newsletter and get pictures of me and my group that we're traveling with and all of the fun things we're going to be doing, I just wanted to invite you to become a part of that. So you can subscribe to my photo newsletter at my website. It's nursecathy.com/Zambia. If you live in the US, there's actually the ability to subscribe to the newsletter using your mobile phone. You just text the word Zambia to 33444. It's going to then just reply back to you. You put in your email address, and then you're subscribed to the newsletter. You don't get any other text messages after that. So I am going away, and I just wanted to let you all know what I'm up to. I don't talk a lot about all the other things I do outside of aEEG very often, but I just wanted to share that with you, and really excited to be able to educate and share my passion for babies and babies thriving around the world with others. So really excited that I'm leaving, and that will be on Halloween, which is October 31st here in the Northern Hemisphere here. So we're going to be taking off on October 31st and back in a couple weeks after that. So I'll be offline and not really available. So just feel free, though, to keep working through the course. And I encourage you to send in your questions, and we'll get back to you when I am back in the U.S. So our next aEEG call will be after I return from Africa. So I'll try not to bore you with too many photos on that call, but November 23rd, it's a Monday at 8 a.m. So anyways, thanks for hanging in there. Sorry for the couple little technical glitches this morning. But I hope to see you all on my return from Africa. So take care and have a great week.